Great. Well, thanks, Mike, and thanks to everyone from Innovasis, Mike, Rebecca, and CJ for your organization. It's a real pleasure for Jim and I to be co-chairing this again, and Brent and all the Innovasis people here, thank you for your generosity in putting us up at truly what I think is the most beautiful ski mountain around. It's always a pleasure to be back here and see some familiar faces and hopefully meet some new people. So we put together a program that I hope is going to really encompass a spectrum of topics within the area of spine surgery. And the first topic is going to be on patient safety and patient quality. I think this is awfully important to start off with because it sort of spans everything we talk about, from MIS work to deformity work to cervical to lumbar degenerative work. And I'm going to start off just talking about the first two elements of this. So patient preoperative optimization and intraoperative standardization. And the next one, I have Jason Hull is going to talk a bit about postoperative accountability, measuring outcomes, and how we're really accountable for the things we do. So during my time, the overview I'm going to go through is this idea of the continuum of care, from preoperative to intraoperative to postoperative, and trying to improve quality at every step along that continuum. I'll talk a bit about surgical risk and the notion of when we think about the appropriateness of surgery. Fundamentally, what we're dealing with is a measure or a balance of risk and expected benefits. And what are the expected risks and indeed the expected benefits of choice? And understanding that is what empowers us and patients to make some informed choices. What I thought I'd share with you is some work that we've done with risk stratification tools, and I'll show you some tools that I actually use in real time in my practice. And then finally, maybe a bit about some predictive modeling, because I think part of the preoperative optimization portion and also part of the intraoperative standardization has to do with predictions of what's going to happen. So one of the things that we'll talk about actually later today is going to be healthcare. I think it's actually tomorrow, but healthcare economics and the notion of the continuum of care, and part of the Affordable Care Act and part of ACOs, part of doing bundled payments, is to really have a focus not just on the apex of care or the episode of care within the hospital, but to try and expand that focus to what happens in the preoperative setting, what happens in the outpatient setting, what happens in preparation for surgery. The more we do in preparation can save our costs both in the hospital, as well as for those of you who are working with bundled payments, the dramatic amount of costs that happen after the hospitalization, so in a recovery period. And preparing for that can really limit some of those costs, and getting patients home, you'll see, is a real big goal. So when I think about the continuum, building that continuum from starting off with non-operative spine work through preoperative, what we call prehabilitation, some intraoperative pathways, working in co-surgeries I'll talk a bit about, working with anesthesia on creating pathways and the nursing staff. And then finally, again, Justin's going to talk more about accountability after discharge and the outcomes that we're responsible for. So I'm going to start off by framing this in a format of risk and appropriateness of care. And fundamentally, when we think about what's an appropriate thing to do for the individual patient, be it a degenerative problem or a deformity problem or a trauma or a tumor, is we need, number one, some valid information on what's the natural history of a disorder. What's likely to happen if we do nothing? And then what's likely to happen if we intervene, specifically with surgical or even with non-operative options? What are the risks of care? What are the inherent risks, and what are the expected benefits? And that balance of risk and understanding expected benefits is what, again, empowers appropriateness of care, or understanding which approach might be most appropriate. It's also important to understand risk and expected risk and to be able to predict this, to really give an accurate estimate of what our expected complications are. So for our quality metrics, so for example, if we were to say that our hospital last year had an infection rate of 1.4%, well, without knowing exactly what kind of cases you're doing, the invasiveness of those cases, were these revision, were these patients who had radiation for prior tumor, or were these all primary cases, 1.4% means nothing in an absolute sense. So it's got to be put into the context of what we're doing and risk stratified. For our patients to have appropriate expectations, but also increasingly importantly for our hospitals to have appropriate expectations, and for our payers, especially if we're working in a bundled payment system, again, for our payers to understand what for our hospitals and payers, since we're sharing risks there, to understand what the expected costs, length of stays are going to be. for resource allocation. And oftentimes we talk about when to say no. More often what I tend to see in my practice is when to say not yet, when to say here's what we need to do to have you adequately prepared for surgery, rather than necessarily an absolute no, although there are instances, we'll show in some cases, where the answer probably is most appropriately an absolute no to surgery. Again, in terms of shared risk models, if we don't have any idea of what the length of stay is going to be, the likelihood of a readmission, likelihood of a reoperation, it's impossible to any responsible way to participate in a shared risk model. And then finally, again, and maybe most importantly, when we talk to our patients, really empowering patients to make an informed consent, especially some of the more complex things we do in deformity, having patients really understand what kind of risk is involved and empowering them to participate in shared decision making. So again, whether it's lumbar degenerative problems or more complex deformity, oftentimes we're making decisions under conditions of uncertainty. Uncertainty with regard to what would happen if we do nothing, uncertainty with regard to what would happen with non-operative care, and uncertainty with regard to what would happen with a small surgery or a big surgery. And that's what leads to some variability in our approaches to care. And fundamentally, especially when we talk about spinal deformity, but maybe even more so in some of the degenerative pathologies that are cervical and lumbar spine, there's a terrific amount of variability. The difference between doing an open surgery and an MIS surgery. We'll have a nice debate from Charlotte and Justin I'm looking forward to, I think sometime tomorrow. But a tremendous amount of variability in how we approach problems. To some extent, what you get depends upon who you see. And it's certainly true in my practice, whether you see me, one of my neurosurgery colleagues, one of my orthopedic colleagues, one of my non-operative colleagues. To some extent, there's still variability within practices and certainly between practices, maybe even more so. And to some extent, I'm not by any means an advocate of being dogmatic about some monolithic or unipolar or just a single approach to problems. I actually think that variability makes sense. I think that there are things that work in my hands that might not work as well in somebody else's hands. There are things that somebody else might work better in somebody else's hands. But more importantly is patient preference. I think having patients well informed and having the variation that we see reflect patient preference rather than surgeon preference really ought to be part of the goal. In terms of variability, again, how can we reduce variability? Well, one of the things that we've been working on is appropriate use of care and appropriate use criteria. And this is based on the RAND UCLA methodology. And most of you are probably familiar with this, but the notion is that an intervention or procedure is most appropriate when the expected benefit exceeds the expected risk by a wide margin. And of course, the opposite inappropriate when the expected risk exceeds the expected benefit. So every Monday at our conference, we go through all the orthopedic spine conference cases, and usually on Wednesday we go through the neurosurgery spine cases, and we get most of our surgeons participating, all the orthopedic surgeons participate on Monday, and most people participate on Wednesday. And I actually bring out this sheet, and we go through, I don't know, Coy, were we doing this when you were a fellow, or some of the other fellows? We bring out a sheet and have everybody rate, is this surgery appropriate or not? And then we say, what's the likelihood of a readmission? What's the likelihood of reoperation? What reoperation? What complication is likely? And we're comparing that to some machine learning tools to see how well we do with the wisdom of a crowd compared to how well others do. And there are situations where my peers may say, I think that's an inappropriate surgery, and that's fine. We discuss those sort of things. In fact, there have been instances, it's not uncommon, where I'll change my plan in response to my peers. I think that's a really good quality metric, those kind of peer conferences and that kind of responsiveness. And then ultimately, the goal is at the end of a year, we're going to come back and we started this, but we haven't completed this yet. But at the end of every year, come back and take a look at, well, what actually happened? What were the observed complications, and how well did we actually predict these? So again, using the appropriate use criteria, we had written a bit about this, and some of the drivers of appropriateness, we did this for adolescent scoliosis, for adult scoliosis, and we're doing one for lumbar degenerative pathology. But some of the drivers of appropriateness included, the preoperative symptoms. Obviously, people with less symptoms be less likely to do an invasive surgery. Progression of deformity and sagittal malalignment, those were major drivers, meaning if patients had a rapid progression of deformity and they had a major sagittal plane malalignment. In general, we were willing to take more risk in those cases than in cases that were stable. And comorbidities, of course, were a major driver. So age, and we'll talk a bit about some of the other modifiable and non-modifiable comorbidities. But those were the major factors that actually drove whether or not surgery was appropriate or inappropriate. Well, one of the other considerations I'm going to bring up very briefly, although this could take the full day, is the notion of when we're making decisions under conditions of uncertainty. There's also a certain moral hazard to this, and the moral hazard occurs when there's a dissociation of risk and benefit. So most of you are familiar with this, for example, with insurance. If you got a very expensive piece of jewelry, then you'd be more likely to wear that out if it were insured than if it were uninsured. If it were uninsured, you're going to probably keep that in a safe. And that moral hazard is something that insurance companies need to deal with as well. You might drive differently if you had just lost your car insurance compared to if you were flush in your car insurance. The classic example is the banks, right? The banks are making high-risk loans. They're benefiting from these high-risk loans because they sell them off to Iceland, and they're not taking any of the risk because they know they're either going to get bailed out, or going to sell off the high-risk ones in a junk bond, but they're getting all the benefit. Well, to some extent, that exists in surgery as well. And what I mean is that when there's a dissociation of risk and benefit, then suddenly decision-making becomes a little bit impaired. And in a lot of cases in surgery, or in medicine in general, this dissociation is that we get a lot of benefit, especially in many cases in doing larger operations, more invasive things. We benefit, and we're not necessarily directly experiencing the risk. Our hospitals take an economic risk, but most importantly, our patients are taking a very real and life and death risk. And George Bernard Shaw, many of you know, the Irish playwright from the 18th century, he actually founded the London School of Economics, but he wrote this play called The Doctor's Dilemma. And in the 18th century now, what he said is that when there's a dissociation between the risk and the benefit, bad decisions are made. And to that end, if you imagine that the executioner gets paid to execute somebody, and if the judge and the executioner were one and the same, meaning the judge also got paid to execute somebody, what he wrote was, nary a neck would be safe in all of Europe. And to some extent, what he's suggesting is that there ought to be some dissociation between the decision-making and the execution of surgery or of a prisoner. And that's where I'm a big advocate in terms of improving quality of care of multidisciplinary conferences and trying to integrate multiple disciplines in care. So certainly spine surgeons at UCSF, we've got neurosurgery. We've got 9 full-time surgeons doing orthopedics and neurosurgery. I know many of the centers, Charlotte's at NYU, have many more than that. We've got physiatrists and non-operative specialists involved. We have neurologists that come to the conferences. We have anesthesiologists coming to the conferences. Our primary care doctors aren't involved. But the idea of trying to integrate and get optimal care from having input from multiple people. And multiple specialists, because there's so many. Let's see, can you just click me through that? That's for some reason that's going to run through all those specialists again, or maybe I can do it. So a big part of, I think, preoperative preparation and preoperative quality of care is going to be to try and have peers involved in conferences. And again, I would say it's not uncommon at all that I'll change my my surgical plan or my plan for an intervention in response to what's happening with my peers. We can go to the next slide if you just put on the next one there. I'll just click through that. These animations weren't intentional. There we go. All right. So let's talk a bit about quantifying risk, and really what's an acceptable risk, and I'm going to talk a bit about complications on Saturday afternoon as well. But the idea being that ultimately we want to risk stratify cases and understand the quality of care is based upon what the expected risk is for a procedure compared to what we observe. And when we think about what's observed, there's a broad spectrum of reported rates. I'm going to go through this somewhat briefly, but one of the areas in deformity surgery we look at is the SRS database, and the Adult Deformity Committee is generally responsible for putting together a paper on the M&M database every year. And this is a paper that was looking at complications in adult scoliosis surgery. If you look at the numbers here, it's pretty small, but the infection rate for deep infections was, I think, 1.5%. Neurologic injury, what was listed as, so acute neurologic injury was about 1%. And those numbers seem awfully small. And that's a voluntary database from a society. And I would argue that probably really underrepresents the observed complications. If you look at some work that we did with the scoliosis, with the ScolioRisk study, 23% of patients who had a 3-column osteotomy had a measurable decrement in their lower extremity motor scores after surgery. Here's some work from the ISSG that we contributed to. 70% of patients had at least one complication in multi-level adult deformity surgery. This is And if you look at the rate of neural complications and infections, in this instance, the neural complications, again, were in the range of 20%. The infectious complications were up about 17%. So numbers that are much higher than we saw with the SRS database. Here's a paper at the University of Washington that I'll refer to again later. Is anybody familiar with the SpineSage database as a predictive model? I'll talk about that just very briefly. But look at the numbers here. Infection in adult deformity surgeries. These are patients who were fused from the thoracic spine to the pelvis was 17%. Neurologic injuries was about 12%. Again, dramatically higher rates. And in part of it is the rigor with which the data is collected. So this is from the Canadian Spine Study Group, where at baseline, using retrospective study, they suggested that there were complications about 23% of their just lumbar degenerative surgeries and adult spine surgeries, but this included a whole spectrum of spine surgery. But when they actually hired a nurse in each hospital to rigorously look at the outcomes, it turned out that nearly 90% of patients had at least one complication, 10% intraoperatively, 70% postoperatively. And to that end, I think there's a lot of variability in the reported rates of complications. So understanding what the expected rates of complication is really important, again, for our informed choice and for our safety issues. Did I just turn this off? I'm having button troubles here. So how do we then predict complications? There are a lot of patient factors as well as surgical factors that might get into prediction of complications. One of the things in terms of predicting is trying to optimize patients preoperatively. And this is probably one of the major things we've done in the past couple of years at UCSF. And specifically, doing a risk assessment preoperatively. That involves our anesthesia team and a prepare clinic as well as our surgical conferences. Looking at the appropriateness of surgery and making sure that our patients' expectations are in line with what our expectations are. So one of the new outcomes tools that we developed is what I call the Universal Patient-Specific Outcome Tool. And that's a tool where we ask patients, what are your specific goals regarding pain, function, and some other goal? I want to be able to golf. I want to be able to play with my grandkids. I want to be able to walk a mile. And in making sure that those expectations are in line with what we expect for the outcomes. And that really empowers the shared decision-making part of the equation. Medical optimization, I'm not going to go through the detail on this, but I'll show you maybe the next slide, I think, is on preoperative medical optimization. This is a dot phrase that comes up in Epic. So if I type dot pre-op up, you see this is my Epic account here. This is what comes up is blood sugar. I don't do elective spine surgery with a hemoglobin A1C more than 7.5. I won't do an elective spine surgery with a DEXA score of less than minus 2.5. Won't do an elective spine surgery with a BMI more than 35. Won't do an elective spine surgery on somebody with a serum albumin less than 3.5. I want to know about patients with infections. Obviously, sometimes that's why we do surgery, but I want to know about their infection risk, prior MRSA. I don't do elective spine surgery people who smoke. I don't do elective spine surgery people who take more than 50 milliequivalents of morphine per day. Now, what actually happens there is if they take more than 50 milliequivalents of morphine per day, they get referred to a preoperative pain consultation before I do surgery on them. I want to know about their coagulation status. I want to know about systemic diseases. And a big part of what I look at preoperatively is what's called a RAP score. Anybody use a RAP score, the Rehabilitation Ability for Physical Therapy score? This is something that's worth taking a look at. I didn't include it in the talk, but it assesses patients' independence prior to surgery, and it's on a 0 to 15 scale. And if you get a score of less than 8, what it means is that you probably live alone, you maybe have a walk-up apartment or a walk-up building many steps to get into, you're already not independent before surgery, and that subset of patients are highly likely to go to rehab or to a SNF rather than to home. And there are things that we can do to adjust the home environment to change that RAP score and make it more likely for people to go home. Some of the other things about preoperative considerations, surgical planning, I'll talk a bit more about that. And then optimizing patients preoperatively, because a lot of these risk factors are modifiable. So we can get patients to quit smoking. In my hands, it's at least 3 months of smoking cessation before I'll do a multi-level deformity surgery or a multi-level fusion surgery. It's a BMI less than 35, and we'll get that to change, including, I didn't turn that off on purpose, including bariatric surgery in some instances. We'll put people on teriparatide and on anabolic medicines for their bone density. So, and of course, the RAP score being a really important way to get patients reliably to go home. Again, surgical planning, a lot of quotes about surgical planning. The one that I like the most is from Mike Tyson. So Mike Tyson was fighting Buster Douglas, and the announcer said, "Hey, Iron Mike, Buster Douglas has got a plan. Are you worried about that?" And if I get the next slide here, what Iron Mike said is, he goes, everybody's got a plan until I punch him in the head. And sometimes that's what it feels like. You go in the operating room, and you have a clear plan, and then you get punched in the head, and that was part of what happened to me yesterday. Why I missed it last night. So anyway, everyone has a plan until I punch them in the head, and being able to change your plan and being able to be dynamic and have more than one plan is awfully important. Again, some of the risk stratification tools using a panel I think is really useful. I'm going to spend my last few minutes here. So case conferences, who's routinely doing a case conference where they're looking at their cases before surgery? I can't tell you, that's the most invaluable part of my week. I virtually never do a case without talking to somebody about it. But some of the models that are interesting, I'll just share with you. I was going to share some numbers somewhat humbly. So you see here, I do the most cases, the most complex cases, but I also have an index of that's longer than one. So I've got people who stay in the hospital a little bit longer. Now, if I wanted to improve that, what I would do is I'd say, hey, you know what? I'm not going to take any transfers anymore. That'd be the simplest way to improve that. So I could predict the subset of patients that are going to stay for a long time. When we think about predictive modeling, for the weather, we know pretty well that it was going to snow yesterday, and it's probably going to be clear today, I understand. But we know that with great granularity or with great certainty because we've got millions of data points. In spine surgery, we don't really have as many data points, but I thought I'd share with you briefly two things that I use. And I was going to do this as an interactive, but I don't think we have time for it. So I'm just going to do it. Has anybody used this sport calculator? We had John Laurie out as our visiting professor last week, and this is something I've used for a while. It's really worth taking a look at. Is you can go onto the Dartmouth website and put in sport calculator, and for people with disc herniation, spinal stenosis, degenerative spondylolisthesis, it'll ask parameters, age, some symptoms, some things about comorbidities, education, some other predictor variables. And for the individual patient, and I can show it to you later, but I'm not going to connect to the link right now. But for the individual patient, will say, well, this is where you are with regard to your present pain, present function, and this is where we would expect you to be if you were treated non-operatively, and this is what we would expect for operatively. And it'll tell you about complications, satisfaction with surgery. And it's not a perfect model, but it's something we're working to validate right now. And I use it for every patient that I treat with spinal stenosis, spondylolisthesis, and disc herniations. And it really helps to put into a context what we expect as a result of surgery. Here's a data set that I mentioned. It's based on about 1,500 patients at the University of Washington out of Harborview. And for 2 years, they collected information about the invasiveness of surgery there, as well as the observed complications. And so, again, a really interesting tool. You can go to SpineSage as a website, and I might have to lick the battery on this or something. And there's all sorts of variables that you'll put in: age, gender, smoking status. But you put in the type of surgery you plan, whether or not it's a primary or revision, some comorbidities, and the output that you get is actually got pretty good fidelity. So if you look at the area under the curve, I'll show you that the AUC was about 0.8, suggesting that the ability to predict length of stay, perioperative complications, and dural tears is really quite high. So again, I've got a link to it, but we're not going to have time to make that link right now. Do you mind if I just ask you to advance it, and I'll lick the batteries? Maybe one. So this is a link to it. Just one more advance, if you would. This was done with Jens Chapman and a group at University of Washington. And that final tool, has anybody used the NISCRIP calculator? This is actually quite an interesting one. As opposed to 1,500 patients, this is based on 3 million patients. So there are about 500 hospitals, there are almost 600 hospitals across the country that are part of the NISCRIP database, and we're one. And go ahead and just advance that if you would. And what this does, this isn't spine specific, but here are the parameters that get put in. So some demographic factors, some patient-specific factors. You put in a type of surgery, and using a database of over 3 million people from NISCRIP, go ahead and advance that one more time. It'll give an estimate of, and this is the interactive calculator, so you can actually do these all online. Advance one more time, please. So you can put in, again, some of the demographics, some of the comorbidities, and I did an example here because I expected that I wouldn't be able to do this in real time. And in a young patient who's otherwise healthy, very few comorbidities, in this instance, this is a scenario of a 3-column osteotomy where the risk for a major complication was expected to be about 8%. But if I change those parameters and turn it into an octogenarian with non-insulin-dependent diabetes, all of a sudden the risk for a major complication goes up to almost 30%. So you see that some of these things that are modifiable have a major impact. But this type of a calculator, and in general, I think the NIST probably underestimates risk, the spine stage probably overestimates risk, but it gives me a framework and a structure with which I can really have some informed conversations with my patients. So one of the things I promised to Mike is I'd be on time. So with that red light, that's my last slide. I think I'm just going to come to my conclusions. And very briefly on intraoperative considerations, blood management, tranexamic acid, nerve monitoring protocols. One of the things that we do a lot of at UCSF is we operate with 2 attending surgeons. We have neurosurgery and orthopedic surgery working together. We do a lot of work with early mobilization after surgery. And one of the big things we showed is getting patients home. And what I mean by getting patients home is that we showed that there was an 11-fold higher rate of readmission in a subset of patients who went to a SNF compared to going home. Going to rehab was also slightly higher than going home. But if we could set things up that patients can go home after surgery, that's going to be the most reliable way of limiting length of stay. And that was the most powerful factor in readmissions. So in conclusion, I think overall spine surgery really involves complex systems. And whether we're doing major deformity reconstructions, tumors, or we're doing degenerative pathology, there's a lot of interactions involved. And I think reforming our systems across the continuum to really optimize patients preoperatively, to create standards within the operating room such that we're doing things consistently. When I first came to UCSF, every single case was an argument about whether or not we're going to use inhalatory or IV anesthetics for nerve monitoring. It was an argument about whether or not we're going to go to the ICU. It was an argument about, more recently, about tranexamic acid. And that's changed dramatically. We do the same thing. It was a different anesthesiologist every time. We do the same things every time in the operating room. And I'm going to give the floor to Dr. Hull to talk about postoperatively and being accountable for postoperative outcomes. And finally, what I just want to emphasize as a starting point for our weekend is that patient safety, outcomes, and the value of surgery can all be optimized if we really make some significant reforms in how we take care of patients. And I think throughout the continuum of care, there's always opportunities for improvement. So thanks for the opportunity to lead this off today. And I think next I'm going to try and fix this clicker with a new battery, and we're going to have Dr. Holm come up and talk about postoperative accountability. And specifically, one of the things Dr. Holm's going to talk about is the Innovasis Registry.